Hi, my name is Peter. I'm an EM resident from Denmark, currently doing my residency in Stockholm, Sweden. My main interest is non-technical skills, and I would love to talk to you today about this topic. Specifically, I want to talk to you about probabilistic thinking, and I'll use examples from the patient group that we would call the headache patient. But most of what I'm talking about will apply to any patient in the ED. Non-technical skills, I usually use an analogy to make people understand what it actually is. If you think of a brick wall like this, you could imagine that the bricks are your knowledge, like your fundamental knowledge of diseases and procedures and so on. But what is actually connecting all of this and what is actually keeping it together is these non-technical skills, communication, decision-making, awareness, and so on. So it's not like one can do without the other. We need both. But in my experience, in med school and in clinic, we are rarely taught about the non-technical aspect of clinical life as a doctor, and that is something I'm trying to change through my blogs, through podcasts, and now through this video as well. When I set out to make this series of videos, I kind of went overboard and made a video that is much more detailed than this one. It lasts for 4 hours and it goes into great detail, and it's with a lot of references if you want to learn more about this. Currently it's only in Danish, but I'm trying to make time so that I can put it up on my YouTube channel in English as well. For those of you understanding Danish or being able to read Danish, I have done blogs on akutmedicineren.dk, this word, and I've done blogs on this topic that I'm going through today in great detail. So if you can read Danish, this is a good place to go to as well. Also, we've started doing a podcast on akutmedicineren, and currently we have a couple of podcasts on various topics. So if you're interested, please check these out as well. Before moving on, I will just quickly show my disclaimer. I am an instructor in EMCC, Emergency Medicine Core Competences. I've been so since 2016. This is a course in Lund, made by an emergency physician there called Eric Driver. It's a non-profit, and I only receive money from there. When I teach, it's only like funding for transport and stuff like that. And all of the people teaching at this course do this like for non-profit reasons. I will, however, say that I will promote. I will do a small promotion for the book because I think it's a great book that we give to course participants. And I know that not all people can participate at this course. It's highly sought out. So so this book can now be bought online, and that's that I want to promote. But I do not receive any money for doing that. Also, I'm currently I've been privileged to be the editor of the 4th edition of the like the teaching book in emergency medicine in Denmark. I do receive a small amount of money for each edition being sold, but this is mostly a symbolic amount of money. I'm also a board member of Young Danish Emergency Physicians, and have been so for 2 years. and I'm a former board member of the Danish Society of Emergency Medicine, DASEM. Currently, as I told you, I do blogs and podcasts on acute medicine and .dk. I do not receive any funds for this. For this particular lecture, I will say that I am not a neurologist. I have worked a fair share in emergency neurology, but I'm not a neurologist, and I'm not a cognitive psychologist. Cognitive psychology being the topic that I will be discussing with decision making in this lecture. Also, this lecture, there is a fair amount of evidence behind this lecture, but it's also high on my own opinion, and that I will encourage you to stay critical and not apply these things without talking to your colleagues and always following your local guidelines. Okay, so the main purpose of this lecture is to challenge your perception of how objective the almighty CT scan is, or the almighty test if you're talking about the broader view of emergency medicine. I will challenge this and tell you that a test is nothing without a decent pre-test probability assessment. And if we do not learn how to do a decent pre-test probability assessment, but blindly follow tests, then we are in great danger of injuring our patients. So pre-test probability is the king. Okay. And we will injure our patients in different ways. We might miss a diagnosis because we are framing or premature closuring or anchoring on something that, well, if the CT scan is normal, then I have ruled everything out. So that's the risk. We go down the wrong rabbit hole if we think everyone with a headache can be ruled out with a CT scan. Also, there's this risk of the cascade of care. Like we find a small incidentalloma, or you might find something false positive on the CT scan. This will engage the cascade of care, leading to either a treatment or a test, and that test might lead to a biopsy, and that biopsy might lead to bleeding, and that bleeding might lead to severe disability in the patient for something that was not meant to be in the first place. Also, I will make a point of talking about the suffering of patients and how we are often missing to address their suffering and their problem and the entire purpose for why they were coming to the emergency department in the first place. If we just order tests and don't do a decent pre-test probability assessment listening to the patient. Okay, so for the emergency physician, usually there are at least two gears, maybe three as shown here. We have a resus mode, a stable mode, and then maybe we have a palliative mode, at least according to Casey Parker. We have this third mode as well. So usually when we think about emergency medicine, we usually are in the resus mode. We want to be good at doing resus. We want to stabilize the patient, but that is only like 5 or 10% of our patient load, depending on what kind of center you're working at, of course. Most of our patients are stable. And the palliative mode is also part of this stability usually. And I want to talk about the stable mode because it's the majority of our patients, and I think it's often neglected and often not thought of as part of emergency medicine, even though it's the majority of our patients. Okay, and one of the main things here is that if we are in stable mode, and if we're in the wrong mode for our patients, then usually we will either under or overdiagnose. So if we're in resus mode when we see our stable patients, then we can injure them and usually deliver worse care than appropriate, and vice versa. Okay, so for this lecture I will be in stable mode, but in in general, you can like the things that I will be discussing are generalizable for all modes in various degree. Okay, before moving into the lecture, I'll just say this about the environment that I'm working at currently. So if we think of the healthcare system as a tree, where we have patients in the bottom here, then we have like the branch specialties like ophthalmology or hematology, or even certain parts of internal medicine is now being more and more highly specialized, being more and more branched out into these parts of the tree. Then we have in the middle here in the trunk, we have the general specialties, the generalist specialties like Einley, which would be private practice, emergency medicine, and intensive care. And I just for this this slide, I wanted to emphasize that the care that we deliver in emergency medicine, the yellow filter, is different from different countries. Like Denmark and Norway are quite unique in that way that the emergency department is a closed space. You cannot enter the emergency department without without permission. You have to see your private practice doctor first, and they have to assess you and then send you to the emergency department. You can go in through 911 or 112, as in Scandinavia it's called, but most patients come in through their private doctor and private practice doctor, and that's a very, very good filter. So the acuity of patients being seen in Norway and Denmark is very unique in an emergency medicine mindset, because it's quite high acuity. In the rest of the world, including Sweden, and I'm no expert in all of the English-speaking countries, but I feel like it's kind of the same there to some extent. The private practice doctor, sadly, is not as strong. Not that the doctors are worse, but they are not being given the resources, the same resources, and the system is not built in the same way. So, for instance, in Sweden, we currently have something called the fria vårdvalet, like free access for the patients. And in my opinion, it's confusing most patients if they have like 37 types of entries into the system. So this means that a patient in my department can come in from the street, and that means that the private practice population can go to the ED, and that is something that might injure them more than not. If we have all kinds of tests, but they are actually very low risk, because all of them might complain of headache, and once they're there and they feel that they need a test, and we don't assess them probably with a good pretest probability assessment, then we are probably in great risk of hurting them through just blindly testing them. It's better. What is unique about the private practice environment is that the private practice doctors usually know their patient, and if they don't know them, then they at least have the opportunity to wait maybe a week. They can use time as a test in a way that most emergency departments can't. And this is a huge benefit, because as Bernard Lown usually say in his blogs and his book, The Lost Art of Healing, most conditions that arise in patients arise because of the rough and tumble of life. This is a notion that is echoed in many books, among others Susan O'Sullivan's It's All in Your Head. And this is not to neglect the symptoms of patients, but it is a way to challenge the notion that every patient with a symptom needs a test. But once they're in the emergency department, they suddenly, there's a flow that needs to be upheld, and usually, for one reason or the other, the patient gets tested, and testing for low risk purposes, as we will see in this lecture, is very problematic and dangerous even for the patients. Okay, so what I also wanted to say about this slide is there's certain schools of emergency medicine, and some of these schools, like some of my colleagues, are more towards the intensive care part of emergency medicine, like they are what we might call resuscitologists, and some of us are more like downstairs care, which would be doing emergency medicine work on the stable population. And what I think is very exciting is asking people which one they are. And oh yeah, sorry, I've done a blog on this particular topic as well, and you can find that on the Acute Medicine blog about differences in Sweden and Denmark and in general between Scandinavia and other countries. And when we compare ourselves in studies like external validation with emergency departments in Canada or in the United States or UK, when we compare ourselves in Scandinavia, especially if we compare ourselves in Denmark and Norway compared to these countries, we will need to assess, take into account that our emergency department is totally different because of our very well established private practice system. Okay, so as I was saying, I like to ask people about what kind of emergency physician they like, and I think we can have both kinds, and I think both kinds of emergency physicians. It's not like you're only a resuscitationist or you're only a downstairs care kind of guy. I consider myself maybe a bit more towards the downstairs care and the stable patients, but I love resuscitation as well, though I might not be as skilled in the procedures of it, at least, as some of my colleagues. But we need all kinds of doctors here. And so I usually use the archetype of Scott Weingart. He's the one usually saying like resuscitationist or upstairs care downstairs. And the other one, and this might be wrong, but usually there was this talk in SMAC, which was excellent, asking whether emergency medicine was a failed paradigm, and Simon Carley was taking the side of the emergency physician being this catch-all kind of doctor. So which one are you? I'm probably more towards Simon Carley, not in skill but in mindset. But it's a good way to kind of think of that emergency medicine is more than just one thing, and it's more than just one thing in different countries. If you're within the different countries, it might be different in different centers. So if you're in a tertiary center only doing resuscitation, then you're probably over here. But if you're in a rural center, or if you are in a very private practice poor condition, then you are more like you need to be able to see every kind of ailments that comes in. You can't just take all the only the time critical stuff. Okay, so this lecture is in 3 parts, and I want to talk about what is our purpose, what is probabilistic thinking in short, and then the communication and optimal data acquisition, how to assess the pretest probability probably in stable patients especially. Okay. So first of all, our purpose. This is our patient of the day, and we can see from our gestalt that she's not dying right away. So she's a stable patient. And what I want you to think about here is, what is our purpose as emergency physicians for this stable headache patient? And you can pause to think about this, but I will go through the lecture with this. So usually we have two main purposes that are like the main paradigm of emergency medicine. We need to find the time critical conditions, and we need to do so in a way so that our patient in front of us is not blocking the time of all the doctors or taking all the resources. We need to distribute the resources towards the waiting room as well, because there might be patients out there worse off than our patient. So it's kind of a utilitarian, there's a balance between deontology and utilitarian ethics. Okay, so if we only think of this paradigm, then if we go back to our patient, then we might, with these obviously stable patients, think, like as I was millennial, we might have all these negative thoughts about, why is she even here? I mean, I can't be bothered even to think about doing a probable assessment here. I just wanted, I mean, just do a CT scan and then she can go home and then she's happy. Next. And that might be a problem, I would argue anyway. So we can view the emergency department challenge as kind of a needle in a haystack challenge, especially with these stable patients. So no pun intended. But so if we think of the entire population of the emergency department, all the patients as the haystack, then what we are trying to find is the time critical conditions, the needle in the haystack. And that's quite easy. Like the do a scan right away before talking to the patient. That is a proper way of doing emergency medicine in certain cases when the needle is very big, because then you have done your assessment already. Just be aware of cognitive biases, but that is a valid way of doing emergency medicine in certain patient groups. Okay, so let's try to think of this. Sorry I didn't translate this, but this is a case I had with a man being out running. He was out running and suddenly he collapsed on the floor. Oh, sorry, on the pavement. And he told us that he had this intense abrupt headache, and just before passing out. And when he came to, he was throwing up, and he had a headache, and he was he had photophobia. So he came in this condition, and I mean, you don't have to have been in med school for too long to know that this patient needs a scan of his head. You could nitpick other conditions that it might be, but I mean, somewhere in this haystack, you will you will say this is a pretty big needle. There is a CT scan coming his way. All right, and this was his CT scan. This is a this is the classic starfish of death pattern of bleeding in the basal cisterns. What you see with a subarachnoid bleed, a spontaneous subarachnoid bleed, and this is like a this is straight from the books, right? This is a like straight from the book example, and I can tell you that this is straight from the book because I was the co-editor of this chapter, and we put this case in as a typical case of subarachnoid hemorrhage. So so that's a big needle, but most of our patients are not big needles. So we might think of the population in the emergency department as a spectrum of signal and noise. So on the far right side here, we do see the classical presentations where there's a high signal or a low noise. And for headaches, that might also be headaches with a neurological findings. If it's not a minor, like a Horner syndrome, then it might be further over here. But in general, headaches with neurological findings are quite obvious usually. Okay, in the other ends of the spectrum, we have the atypical presentations, the complex and the comorbid patients, and the pain presentation, like all pain presentation, like chest pain, headache, abdominal pain. These symptoms are complex. They're not simple. They are, as we will go into in a little bit, they are complex in a way. Because of they stem from both biological, psychological, and social events, and whether you have a huge headache or a minor headache doesn't really play in. You can have a very, very severe headache just from psychosocial events, and that doesn't show if you don't do a decent assessment of your patient. Okay, so. Right, so you have these over here, either a high signal, as we saw in the case, or low noise. And the low noise is usually your young patients having very obvious symptoms. You can also have a low signal, and that's usually in your elderly patients, where they come in with very minor symptoms but might have something severe. And you have the conditions with high noise. Maybe the patient I just talked about, maybe he had maybe he was framed in a different way from the ambulance. There was a lot of noise in the information. Could be that he came in, they didn't say anything about headache. They just said that this 50-year-old man had had a syncope, and they showed me the ECG, where you do see some unspecific changes, and he's bradycardic. That kind of constellation of symptoms, and that kind of framing and that diagnostic momentum might create enough noise. Even though the signal might be good and big, it might create enough noise for me to be distracted. So even classical presentations might have a lot of noise and make them hard to detect. Most of our patients are in this category. It's rare that we see these. You don't have to you don't have to have been clinically practicing for a long time to know that most of our patients are in this category. The signal to noise ratio is usually not that high, or it's at least ambivalent. Yeah. So if we take our analogy here again, and if we do a CT scan just blindly on these patients, then we are in great danger of doing a we're in great danger of overdiagnosing sometimes and doing the patient harm. So how is that? I'll try to explain it like this. So for each time-critical patient event, for each time-critical condition that we're finding in a patient, we are scanning or testing a certain amount of non-critical patients. We can never have a 1-to-1 ratio, because that would mean that we are underdiagnosing our patients. So if you do a scan and every time it's positive, then you're doing something wrong. Then you're being too scarce with your testing. So usually a good hit rate would be like maybe 1 in 10, depending on the condition, but like maybe 1 in 10. So what is happening if you don't do a pretest probability assessment, a decent assessment of this? Then you will increase the rate of, you increase your hit rate, which is bad. Like your and the amount of scans that you're doing will increase. In certain centers, I know they're looking at these numbers for different doctors, and they're trying to make the doctors with a high hit rate talk to the doctors with a low hit rate, so that they can share their knowledge. The ones with a good hit rate, what are they doing that the doctors with a high hit rate are not doing? And stuff like that, like learning Gestalt from an expert. That is a good way probably to get rid of this. Okay, so Another way to look at this is by looking at this diagram, which I think is excellent, from Gilbert Welch's book Overdiagnosed. He's also explaining this graph in his YouTube video series on Less Medicine, More Health, LMMH. So we might think of a specific condition, maybe PE, pulmonary embolism, as a spectrum of severity, right? And on the y-axis here, we have the aggressiveness with which we will want to diagnose or work up our patient and manage our patient. So we have our needle in the haystack here. We have time-critical patient here, and they will have the maximum benefit-harm ratio, right? They will be the ones that, and we can discuss whether much of our treatments work, but if they work, they are the ones that are usually the ones to get the most benefit out of doing maybe a PCI or getting Eliquis or some other anticoagulant for a PE, right? Notice that the harm rate is straight, right? It can be argued that it is straight, and Gilbert Welch is arguing that it is straight. And for details, you can look in his book for why it might be straight and not maybe just sloping one way or the other. But in general, we can think of, for most conditions, that this harm rate is straight. So if we treat our pulmonary embolism patient with anticoagulants, then there will be the same harm for a big saddle embolus as there will be for a mild subsegmental embolus. And that's where we have to, this is something that we have to take into account when we are testing without thinking. Because if we are testing without thinking, we are pushing our patients into this realm of low value care, as you might call it, as the Lown Institute and the Right Care Alliance have talked about for a long time, as Jerome Hoffman has talked about for a long time, as a lot of very smart people have talked about for a long time. This low value care and this kind of you might say creep, diagnostic creep towards the left of this spectrum. So this is how we can, one way of harming our patients if we do blind scans, right? And one of the problems might be that we call everything on this spectrum PE. We don't. And this is something that they are especially talking about in cancer research, but also should be talking about in emergency medicine. That the thyroid cancer that is very dangerous should have another name than the one right down here. Ray Moynihan has talked about this, and Glashow and Ioannidis and Ioannidis and others have talked about this. And we are talking about this for certain conditions like PE, subsegmental, segmental, but still the treatment is still the same. So yeah. Okay, so there are other reasons why we do tests instead of watchful waiting or talking to our patients. And one of in the center of this problem is something called the risk proximity problem. The risk proximity problem is the notion that if I work up my patients for PE and I do not do a scan because I don't think they need one, but they go to another doctor tomorrow and do a scan and they find a PE, then I have a problem, because then they found a PE that I quote unquote missed. So it's better for me, even if I'm a little bit in doubt, just to do a test, so that I can so that quote unquote objectively I can show that I have done a reasonable assessment. And the notion that a reasonable assessment is not only clinical judgment is something I find appalling. If you're below the diagnostic threshold or of a test. But that's a risk proximity problem, that we are afraid. And the thing is, like, summing up this problem is that there are certain advantages of just doing the test for the doctor. Jerome Hoffman, an emergency physician in UCLA and a professor of emergency medicine and a legend of emergency medicine, as Ken Milne usually say, has these lectures, has been talking about this for a long time, and has this great BMJ podcast on the topic that I will be linking to in the bottom of this slide shortly. That if you, so if let's say that your patient is demanding a scan, you have a headache patient, she or he is so afraid, she's demanding a scan. You don't have you don't think that you have the time to talk to this patient and your assessment has been done that you don't think it's a high risk patient, and you don't think it's reasonable to do the scan, but the patient is demanding it. Then Jerome Hoffman talks about the fiduciary duty of the emergency physician or the doctor in general. Like, the reason why we became doctors, like the societal reason, is that the society needs someone to be experts at this stuff. Like, when you become ill, when you fall ill, you can't just Google something and then think that that's like the answer. It's more complex than that, and that's why we need an education for several years and need to practice and so on and so forth. But through all this testing, that has been neglected. Jerome Hoffman says that we should the doctors, like, as a payment for us being taught this expertise as a societal privilege, we promise to always make the patient's interest, like, put the patient's interest above our own. Yeah. So that interest hierarchy is sliding now, because, like, it's much more beneficial for the doctor in this patient case to just do instead of not do, to just and Jerome Hoffman comes up with several reasons for this. Like, one of them is, well, sorry, I haven't translated this slide as well, but some of the, like, reasons why this is much more beneficial for the doctor to do this is, well, it's considered time effective. I will argue against this later on, but it's considered time effective. I don't have to talk to you right now. Like, I don't have to talk to you anymore or any longer. I can go on to other patients. I can just order the test, and then I can come back when the test is done. I perceive that there's a lower risk of error, at least for me. It's a lower risk for me as a doctor. Even if I don't think I will miss anything, if I just do the clinical assessment. But if I miss anything, I know there's, like, maybe 1 in 100 risk that I might be missing something. And if you go to another doctor tomorrow, and then I might be in big trouble. You will sue me, and I will think that I missed something. That might lead to burnout or second victim, or and I can cover my ass by doing just this test, because it's viewed as more objective. It's even measurable. I might even get money for doing this. My administrators can see that I'm doing something instead of communicating, which is often unmeasurable, even though and that is a problem in and of itself. And I might be sleeping better because I will be tolerating. I might be intolerant of this uncertainty that goes along with not doing a test. And if I do the test, well, I might be sleeping better then. Okay, so, but there's a huge risk for the patient here, because we're not living up to our fiduciary duty if we do this. As Jerome Hoffman tells us in this case, he tells the patient that, well, I mean, I have all this huge list of stuff that I that I can come up with, which is in my interest, just for just doing the test, just do the CT scan. But there's one reason why I can't do that, and the reason why is that I promised to put your interest above, always. So above my own, always. So there are, and the reason why he's saying this is because he knows that there's these risks if you have a low pretest probability assessment of a patient and doing a test anyway. There's this huge list of risks, right? So some of these risks are premature closure. You might be going into a I mean, just doing a test, you might anchor on the wrong kind of framework. You might even find something on the test and which was unexpected, and you don't know how to interpret this. Justin Morgenstern has done a great short blog on this called "Why Pretest Probability is Essential" on First 10 EM. Okay. More importantly, or at least as important, is they don't listen. I mean, that's what the patient will say when they go home, when you just do a test and you just send them on their way. So you're not addressing the concern of the patient, and that is usually the reason why they will come back. Also, Iona Heath's concern is that there's overdiagnosis, and with all overdiagnosis there's underdiagnosis. So somewhere in the system, someone is not getting that CT scan or not getting something else for that resource that we're using and spending on this patient, especially when the currency of the system is something that is the currency of the system is measurable stuff. So if there's measurable stuff like CT scans, well, then all of the unmeasurable stuff, which might be more important, is kind of boggling underneath all of this measurable stuff, which might be low value. Okay, and then we talked about this cascade of care, that if we do find a false positive or incidentaloma or something, that, I mean, we might induce more anxiety of the patient, and we might leave them on this path of disease, as Gilbert Welch calls it. Okay, so I urge you to think a bit wider on what emergency medicine is and what our purpose is. And I think Ruben Strayer in his EM medicine talk on YouTube also talks about this, that reducing suffering should also be part of our duty. Ken Milne usually says this: numbers needed to treat equals 1. Like every time we see a patient, they should be better as a consequence of our meeting with them. Doesn't mean that they need to get everything they want. Doesn't mean that we will fix their problem, but because we usually can't. But it means that we can get them to the next step in their care. It means that we are compassionately trying to do the best for them, and just the notion that we're trying to do the best and actively listening is usually enough to make them feel that that numbers needed to treat equals 1, that they got something out of the visit. Okay, so we should reframe our stable patient. Instead of like all of these negative thoughts, we should reframe and try to think of them as someone, like, what is their road to the emergency department? Why did they have to come now? And they're obviously suffering. So I should try to get underneath that and try why is that the case? Okay, so this is complex, right? We can't just reduce suffering, because then we will miss all the time critical conditions. We can't just do the time critical conditions, because then we won't reduce suffering in the same way. We can't order tests on everyone, and so this is complex, right? And that is the art of emergency medicine. We need to be able to do all this stuff at once. Or try to achieve all of this at once. And how do we do that? Well, my recipe for this is this, and it might be a simplistic one, but I will try to guide you through this in the end of the lecture. That good communication achieves two things. It achieves better diagnostic value and better treatment of the patients. Okay, so before moving into that, I'll just go through probabilistic thinking in short, because I don't know how much of this is taught where you come from, but I'll just go through it fairly quickly. And if you want to listen to a more deep, in-depth conversation about it, then I urge you to look at our blog or check out the longer video once I post it in English. All right, so for probabilistic thinking, you need knowledge. So how do we get this knowledge? Well, in emergency medicine, we are especially, as I told you, we are especially interested in the time critical conditions. If we have like all of the conditions here, if 100% is all of the conditions that we can think of for a headache patient in the emergency department, then certain studies, Chu et al., talks about that it's only 3% of them that are time critical, right? And we want to know details about this time critical condition. We might also want to know something about these, the most common ones of them, but these are our main conditions that we want to be experts at. So how do we zoom in on these? Well, I mean, you can definitely look up these diagnoses, and our purpose in emergency medicine is not to mainly make diagnosis. It's to change the probability landscape of and the patient's risk. But in order to do so, we need to know about these illness scripts. We need to know about the symptoms of these so-called illness scripts. This is an illness script. This is an illness script. Like all of the white is a illness script. So just to hammer home this point about a test is not like almighty, I'll just show you which of the like for all of these headache, like all of these time critical headache conditions that a emergency physician might be interested in knowing about. The CT scan will be a good test for these conditions. Like in almost all cases, it's really good at finding bleeding, and invariable, like it will in some or most cases be good in these conditions. For instance, but it's only with certain kinds of conditions, right? So subarachnoid CT is a good test if you do it within 6 hours, maybe 12 hours. In RCVS, a normal CT will not do. You will have to do a CT angio. In central venous sinus thrombosis, you will have to do a venogram, and so on, right? So that we really need to do the pretest probability assessment well before knowing what kind of test we actually need to order. There is no such thing as a rule-out catch-all test, especially not in headache. Okay, so the white, the conditions that remain white are the ones that where the CT doesn't do anything. And it's, for instance, a very important condition that is often missed, preeclampsia, doesn't need anything along the lines of CT. They need dipstick urine or blood tests, right? So we might think of these, so we talked about these are illness scripts. We call these illness scripts, where you know the prevalence, where you know the diagnostic tests, where you know the most important symptoms and signs, and then you have these constellation symptoms, like where there are more than just one symptom, a couple of symptoms that gather to form this constellation, of which we would call a syndrome. And these syndromes are extremely important in emergency medicine because, not just in headache, but in general, they're extremely important to know about, because the pretest probability of time critical conditions in headache, 3%, goes up vastly when you have the constellation of abrupt headache and intense headache, right? The pretest probability of thunderclap headache for time critical conditions are along the lines of maybe 20 or 30%, according to certain authors. ETLO or in the emergency headache book, but at least subarachnoid hemorrhage is like monosymptomatic thunderclap headache. There is a 10 to 15% chance of that being subarachnoid hemorrhage. So these we want to find out whether the patient lives up to these syndromes. Here's a syndrome of fever and headache, pregnancy and headache. And these are conditions where the pretest probability of time critical conditions become much bigger, right? Okay, so from each of these illness scripts, we can build a database of symptoms, right? Of red flags, symptoms and signs. And in headache in particular, we usually have this thing called Snoop 10, which is like a checklist of all of the things that we need to be aware of and ask about in our patients. So we might think that we could just so a good way of getting the knowledge for the background knowledge for our probabilistic thinking is to think of all like the presentations, the common presentations in your emergency department. Take the time critical conditions of these conditions and distillate them down into make a list like I have made here with syndromes and illness scripts. And from these syndromes and illness scripts, you can distillate further down and get a checklist, right? And Ruben Strayer has done something similar and has done this wheel where you can plot in your headache, your belly pain, your chest pain, and you can kind of get an overview of the conditions that you need to know about. Just to notice that for an emergency physician, here's a condition that has two different presentations. That is where our expertise is. Whether a patient comes in with chest pain or they come in with headache, we need to, in the right conditions, we need to think about CO, like carbon monoxide exposure, right? So that's the one of the forces of the emergency medicine specialty, that we should have it on our radar that a belly pain can be a acute coronary syndrome or All right, so this is where I'll come to with the promotion. Someone has actually done something similar to this kind of distillation down of symptoms into the important red flags, and even put on likelihood ratios on each of these. And that is Eric Driver, who's done the Emergency Medicine Checklist Compendium. You can go into LUCEM, which is the homepage of EMCC, and actually come with feedback to each of these chapters. And again, I don't receive any money for doing this, but it's the only book that I know of that has this kind of method built into it. Okay, so that was knowledge, but knowledge isn't enough. We need to be able to interpret the knowledge that we receive from the patient and see if it fits with our own knowledge. And for this, we need Bayesian thinking, and Bayesian thinking is this huge topic that I've been talking about for a long time in my blogs, and for details look there. But I'll just quickly go through this, because Bayesian thinking is, in a nutshell, the notion that a test is not objective. A test cannot be interpreted without a decent assessment of the pretest probability, because the value of the test depends on the pretest probability. Okay, and that means that patients actually don't have diseases; they have probability of a disease. So, and in emergency medicine, when we admit someone and the department doctors afterwards say, well, why did they admit this patient? They often forget that they might have had a maybe it was 95% like certain that they had a benign condition, but the 5% risk of them after the workup having a time critical condition made it unsafe for us to discharge this patient at the time. So our conditions. So our one of our purposes in emergency medicine is not to diagnose, but it is to reduce the risk. And if we cannot reduce the risk any further, then we have to admit the patient, even though we don't think that's the diagnosis that we're admitting them for, or the reason why we're admitting them is very likely. But if it's a time critical condition which is life-threatening, then it is valid to test them down to a certain post-test probability, and this notion of acceptable miss rate, as we sometimes talk about. We don't know where this line is in different conditions. In ACS, it might be at 2%, as the American Association of a College of Emergency Physicians are saying. In PE, as Klein is saying, it might be at 2% as well. But usually we can't get them further down than a 2% post-test probability, right? So at least not without injuring them, as Gilbert Welch is implying. Like I usually say, the 2 last percent of a diagnostic workup, if the patient is really pressing us on doing that, is really, I usually tell them that is really expensive on their part to do this, because they're in high risk of overdiagnosing if we go any further, or harm in other ways, right? So, okay. So along the line, moving on with this Bayesian, like the rules of Bayesian thinking, or some of the take-homes of Bayesian thinking, is that diagnostic tests make a revision to the probability of the disease. And if we could, they don't diagnose, like a D-dimer doesn't diagnose a PE. It revises the pre-test probability to a post-test probability, right? And all of our tests do this. Like, and when I say a test, I mean everything from paraclinical test to a examination finding, to a pretest, to a question. And as we will go into later, it's not always these tests are not always objective, or they're mostly not objective. They have a inter-rater reliability, and there's a huge gap in quality among clinicians on how to collect this data through communication. So even though we think of it as objective tests, and we think of this as being something that we can calculate mathematically, it's not, at least in my opinion. These things, these diagnostic and treatment thresholds are important concepts that Kashira and Pauker first published, and the diagnostic threshold would be if you have done a decent pre-test probability assessment. Then if you have gone over the diagnostic threshold, then there is more benefit of doing a test for the patient than not. As similarly, if you reach the the therapeutic test threshold of a condition, then there's a bigger benefit of just treating the patient. And these diagnostic and treatment thresholds, they move up and down depending on the condition, depending on the situation. So a young patient with an aortic dissection has a risk of an aortic dissection has you will do the tests. The test threshold will be very low, and as well as the treatment threshold. But if we change the case so that it's a elderly, maybe a nursing home patient, then your diagnostic threshold might not be as low. I might throw in that she's also on dialysis, and there's huge risk on doing the test as well, and also the treatment I mean, there won't be a good treatment for her either. So for the same condition, the treatment and diagnostic thresholds are different, right? Also, like the paraclinical tests are not necessarily better, as we talked about. And there's this great notion that if the outcome of a test will not change the management of a patient, you shouldn't order it. That's like something you learn in med school, but this is the reason why. Bayesian thinking is the reason why. A test cannot be interpreted without an evaluation of PTP, pretest probability. I've hammered that take-home point down. And these two last ones are important. Like a low pretest probability requires a good test for rule-in, right? So if you have a, so let's say the usual notion here is like screening tests. So if you just screen with, let's say if you do a genetic test on a patient who asked for that her minor neurological symptoms might be Huntington's chorea, and you do this Huntington's chorea test, even though it's a good test, is a really rare condition, especially without in a young patient with minor neurological symptoms. And if it's positive, then it's more likely to be false positive than true positive. So low pretest probability requires a good test to rule in. It might change your pretest probability to a post-test probability of, I don't know, 1 or 2%. But we often think of tests as being dichotomous, like this is positive, therefore you must have Huntington's chorea, but that is not the case. The YouTuber Veritasium has made a great video explaining in layman terms the Bayesian thinking, Casey Parker has done a great smack talk called Bayesian Thinking and Odyssey, which goes through this thinking as well. Okay, and the flip side of this is that I should say high pretest probability. A high pretest probability requires a good test to rule out. So if you have your patient with a huge spontaneous abrupt pain in their chest, and even they might even be have Marfan syndrome, and your colleagues tells you that, well, I ruled it out because the D-dimer was normal, then you should be concerned, because your D-dimer test is not good enough to rule out an aortic dissection on a high pretest probability patient. You need a really good test for that, and sometimes different good tests testing different kinds of pathology, like a D-dimer would be good in combination with the CT scan if the pretest probability, if the pretest probability is really high, right? But you need the CT scan, the good test, if the pretest probability is high. Okay, I'll try to give you some more examples here. So this is a test that was read normal, and your colleague tells you that, well, this test is normal. You can send him home once the description comes from the radiologist. So how concerned would you be, depending on whether your patient is a 30-year-old male with thunderclap headache, a 50-year-old female with featureless headache, a 20-year-old male with chronic head or neck pain, or a 70-year-old male with fever, confusion, and headache? So these are all different pretest probabilities for different conditions. So for the first one, remember, it was you was told that this test was normal. But what I'm trying to challenge is that there's no such thing as a normal test. It really depends on your pretest probability assessment. So is this test normal if this was this patient? Well, if the test was done within 6 hours, and it was read by a experienced radiologist, then yes, it is a really good test, and then you will be able to usually send the patient home, insofar that they don't have other symptoms, neurological findings, or something else that might increase the pretest probability. These two, you might say that why did the scan, was the scan done in the first place? Because well, the age thing is actually a Snoop criteria, and I mean it's a low risk Snoop criteria, but it might be valid to do a test in this patient, but it's like on the border of what actually needs to be done. But in this patient, you might think, why are we doing this scan? And it doesn't really change the post-test probability a lot because the pre-test probability to begin with was quite low. Okay, in this last patient, I mean, you would be concerned that this test is not normal, or it at least doesn't rule out that there might be something serious going on, right? You might have done the scan because of you wanted to do it before a lumbar puncture, or you might be concerned about an abscess or something like that. And here was the MRI scan after a couple of days for this patient. And looking back, you might be able to see a small point here, but I mean, you have to assess it in the light that it was presented, right? So a test is not objective. You have to assess the pre-test probability and always look at it in that light. Okay. Another example here is so a couple, maybe a year or 2 years ago, Dr. Smith's ECG blog and Scott Weingart and a couple of other guys did this OMI manifesto, and this is a quintessential probabilistic manifesto, because the paradigm we had before was that either you have an ST elevation myocardial infarction or you don't. That's like a dichotomous test, right? That's either it's positive or it's negative. But we do know that like a lot of the non-STEMIs in this paradigm, in this STEMI non-STEMI paradigms, a lot of the non-STEMIs, they have an occlusion myocardial infarction, an OMI, which is actually the thing that we want to check out. Right, so we're missing a lot of OMIs in this paradigm of ST elevation. It's not that the ST elevation is unimportant. It's just that like ST elevation is a significant, really good test. It has a higher likelihood ratio that your patient would have an OMI if they have an ST elevation. Like it's like 75% chance of that being true. But so let me try to explain it through this ECG. So you have here an ECG, and if you just you don't get any other information about the patient, and I hate when my nurses do this. I at least just want a few. Why are we doing this ECG in the first place? Is it chest pain? Is it syncope? Is it just a screening ECG because they had a headache and for some reason someone wanted to do this? So if you don't get any information at all, you might say, well, okay, there's a ST elevation here in 3, here in 2, and here in AVF. And there might even be a reciprocal change here. But who is the patient, right? So if I told you this patient was a 60-year-old male with clenching chest pain and sweating and vomiting, and the pain is not going away on nitroglycerin, then you will be really, really, really concerned, even though the ST segment elevation might not live up to the definition of ST elevation, right? Go see the OMI manifesto, please. All right, but if I told you that this patient was your headache patient with a featureless headache without any like chest pain or syncope or anything, like, or family history or anything, or then you will say, well, this is probably a normal variant, especially if I told you that this ECG looked like that like 5 years ago as well. So it really depends, right? So it depends on the pre-test probability, even the ECG, which we usually think doesn't. So that's a misconception. Okay. I like to say also that your radiologist is not a robot, right? the pretest probability that you convey to your radiologist is so important, because they are looking at these. They are, if you don't do a decent pretest probability assessment for your radiologist, then you will be doing the same as some of my nurses sometimes do for me, like just putting an ECG in front of me and saying that is it normal or is it not normal. Well, that depends, as I just tried to hammer home. It depends on the pretest probability assessment, right? So are there certain tests that are so obviously positive that there is no need for a pretest probability assessment? Well, I mean, as I told you in the beginning, sometimes the needle is so big that you don't need that much information. Your 90-year-old patient who is pre-comatose, who is comatose with a right-sided palsy. I mean, if you didn't have this information and you just saw the CT scan, then with a huge bleed on the left side, well, I mean, yeah, then the signal is so big that you don't have to know a lot about the patient to do a decent pretest probability assessment. You do know that this is pathological, but most times that is not the case, and you can still misinterpret if you some of these tests that are so high signal because of cognitive biases. You might say that it's the wrong kind of pathology, and you might over or under assess it. So again, pretest probability is a must always. Okay, just to hammer home this point of the test being not that important, or it depends on the pretest probability, then I'll just look at this test, the CT scan within 6 hours in an SAH suspected patient, like a thunderclap headache patient. So if your patient is not thunderclap headache, just random headache, then you might have a very, very low pretest probability. I just put it on for 0.5% risk for this kind of headache, for this kind of condition, and the test with data from Perry et al. On the CT scan, you will see that it has a negative likelihood ratio of 0.01. Okay, so what if you have a abrupt headache? Well, the pretest probability is a bit higher, but not that much higher. And an abrupt and intense headache. Well, then you have then you have the diagnostic criteria for a TCH, right? A thunderclap headache. If you have the case that I just presented, the TCH plus a syncope, then you will have a higher pretest probability, and further if there's focal neurological signs. Here we're only looking at the risk of subarachnoid hemorrhage, right? We haven't ruled, even though you might say, well, TCH, syncope, and focal neurological signs only a post-test probability of maybe 2.5–3%. of this being a subarachnoid. Well, yes, but there's, as I showed you under the thunderclap headache conditions that you also should think of. Then there's a now the post-test probability is 3. Okay, so then there's a 97% risk of something else, right? And how many of those 97% is a time-critical condition? Well, if you have focal neurological signs and syncope and thunderclap headache, it's probably a very, very high likelihood. So maybe 80%. So what does these other 80% consist of? Well, maybe we should do another kind of test, maybe a CT angio or something like that. We do always have to remember that our assessment of this is what is important, and that's what I will talk about in part 3. Like, if our assessment of this is wrong, that is actually might be functional symptoms like functional focal neurological signs, and it's not a syncope. It's a pseudo seizure-like condition. It's a dissociative condition, and the headache probably wasn't the thunderclap. Then your precise probability, even though you have this, well, on paper you have this kind of combination of symptoms, it's probably much lower. And that's why the assessment of how do we collect the data is so important. But we'll get back to that. Okay. I'll also say that this is not math. I mean, we shouldn't carry around calculators. We don't know the precise probability of a lot of the stuff, but it's the concepts that are so important that we know about it. We have to know how good are our tests. We have to know the ballpark, right? And the same with the precise probability assessment. We kind of had to know what our illness scripts looks like and how common they are, but we don't have to know exactly. Okay, so through this entire thing, I've said that precise probability is king, right? So how do we actually, what does the precise probability actually consist of? So this is I forgot to say, this is the Fagans nomogram, where you have the precise probability here, you have your likelihood ratio of the test here, and then you have your post-test probability here. So if we take our just a random precise probability here, then whether the test is positive or negative depends on the precise probability, as we have talked about. So what does the precise probability consist of? Well, it consists of epidemiology, right? Big population studies might, in your kind of setting, in the Swedish emergency, for my setting, it's the Swedish emergency department. How many patients presenting with with thunderclap headache has a subarachnoid hemorrhage, right? And there are some studies like that, not always, and then you have to extrapolate and see if you can externally validate a study maybe from Canada or UK. As I talked about in the beginning of this lecture, it's really hard to do so, especially if you have a totally different system like in Denmark or Norway, where you have a higher acuity of patients. Well, you have to like do with what you have, right? And sometimes your local knowledge of epidemiology is better, like your informal knowledge of epidemiology is better than the more widely accessible population evidence-based medicine kind of information. Then you have your maples. Medicine, allergies previously, leisure, ethanol, and smoking. It's like the background information about your patient. If it's an elderly patient or if it's someone who has had previous subarachnoid hemorrhages, then the risk is higher, then the precise probability goes up, even though the population-wise probability would be 10%. Then maybe if it's an elderly patient, then it's probably 15 or 20%. And the reason why that can be is because the epidemiology is usually an average, right? It's an average of all the conditions and within all age groups, and right now you're picking out, you're being a bit more specific with the age groups when you get the background knowledge, so you can kind of zoom in a bit on the precise probability through that. And you have to know about the illness scripts, what kind of tests. So if we talk about the precise probability as the precise probability just before we do the CT scan test, then the precise probability consists of all your questions, all your exam findings, and all that you have done to assess the precise probability, right? But if you haven't met your patient yet, then your first question can also be thought of as the test, right? That's maybe you've asked, did the pain come abruptly? Then that is a test in and of itself, and with a positive and negative likelihood ratio, depending on how you ask the question. So, and I'll come back to that on how we should ask our questions to get the best kind of precise probability assessment. In the end, also this is also this quality and quantity of the data collection, and I'll come back to that. So this is more like population, a bit more objective, a bit more sciencey, and this is more individual situation expertise evaluation and questioning of how the condition has arisen. Okay, and that is a hugely important thing, that the notion that we can apply a rule if this condition arises, apply that treatment, ignores the ability to judge whether the condition has arisen. So the pretest probability assessment, you cannot just blindly apply evidence-based facts about the condition to your population, because you need a subject, you need judgment to know whether this condition has arisen. And that is often neglected in our, we think of, well, you have a chest pain, well then this condition must have arisen, and we can use the Wells score to rule out that, and we can use the Hart score to rule out that. But if you go into maybe MedCalc online and go into the Wells score, and you will see that Dr. Wells has actually said that, well, you shouldn't do the Wells score on everyone with a chest. There is a judgment involved here, and that's often quite hard to figure out throughout the papers. Like 100 doctors have done this assessment, and how did they do that assessment? I mean, and how can I apply this to my patient if I'm not doing the same assessment? Like, I mean, this is hard, and we're often not talking about this expertise, this essential expertise of knowing when a condition has arisen, especially when the needle isn't that big. And how can we get this information so that we can remove some of the noise and actually get good data? Well, that's what I wanted to talk about in the rest of this lecture, because information acquisition is what I think is the most amazing and most interesting thing that we're not talking enough about in emergency medicine and in medicine in general. So we have our patient, and let's say that we want to know whether our patient has thunderclap headache or not. Well, there's a checklist that we can check out. There is this ICHD-3, the official headache diagnosis list, where they define a thunderclap headache as a high intensity headache of abrupt onset. So that is the criteria, but how do we know if the condition has arisen? How do we ask the questions in the right manner so that we don't lead our victim into this diagnosis, but actually give them a chance, or give the entire conversation a chance to actually know whether this is something that has arisen or not. So there is a difference between the quality and the quantity of information here, and the poll that I just spooled through was the question there is, well, what kind of questioning do you want to do? Do you either want to do the specific kind of questioning where you just do the checklist, like did it come abruptly and was it an intense headache? Or do you want to do questions where you do open-ended questions and from the history try to pick out these criteria through the way the patient tells the history? Well, so I would argue that, especially in the beginning of the conversation, you need to do the latter, not the former. If you go with specific questions too early, you will often frame yourself for anchor or premature closure, or you will not listen to the patient, and so on and so forth. So I'll just do an analogy and another analogy to hit home this point. So this is a random study from PubMed. If we look at the results, then that's where we get the data from in this study. So if I read the results, then I'll be able to apply this to my clinical condition. Well, not so fast. What you actually need to do is look at the methods, because I can only rely on a result on the data when I know what kind of methods were used to acquire this. And this is really important. It's not only in science, but it's really also in clinic, how like if one of your colleagues comes over and tells you that, well, this patient has a thunderclap headache. Well, I mean, we should always trust our colleagues, but and especially if they're expert. But if they're a senior and if they're good, and if we know that they're good, but they might not be expert in this particular area, especially not communication-wise, how to get this knowledge, from the patient. So it's important to. I usually ask, what kind of questions did you ask? Because if this is a thunderclap headache, then yes, I have to do a CT scan, and if the patient presents after maybe 6 or 12 hours, then I have to do a lumbar puncture. The patient has to stay here for a long time, and these things have consequences. So I think it's important to know how was the questions asked, and if you sometimes cannot assess that, then you have to go to the bedside and do them yourself, knowing that the patient might have been primed at this point, so that they will just say whatever they have just been primed for. Okay, so this notion that data has different quality is something that is like spread throughout, like it's old knowledge in our medical books. Like Osler has talked about this, and Jane Fuller here in the Neurological Examination Made Easy, which is, by the way, a great Made Easy book. I hate Made Easy books, but this is a great one. He says, like, remember that the spontaneous reported symptoms is much more significant than the one obtained on direct questioning. And that's true. And that's my point. It's really important how we gather this information. Okay. This is from The Signal and the Noise, one of the lectures on YouTube by Nate Silver, who also wrote a book about with the same name. And what he says is, well, we have if we just blindly, I'm slightly extrapolating what he's saying, I should say. I'm paraphrasing here. But if we have the amount of noise or signal on the y-axis here, and we have more and more data on the x-axis, then if we just blindly collect data without being careful, then we will just create more noise, right? We will get more knowledge, but there's this huge like noise ratio to this, and it will make the true signal so hard to find. So it's really important how we collect data, and if we collect data the right way, probably our true signal will get better and the noise would get less. So just blindly collecting data, just ordering the CT scan might not be the best way, or just asking questions from a checklist might not be the best way. So what is what is the best way? And there's just an example from Jane Fuller again here. For example, patients rarely volunteer that their headache gets worse on coughing or sneezing, and when they do, it suggests raised intracranial pressure, like if they do it spontaneously. In contrast, many patients with tension type headaches and migraine will say their headaches get worse in these situations if directly asked about them. So there's definitely a notion that questioning and how we do the questions and how we obtain the data is so important. So these are the two like frameworks that we're talking about. Either we have a framework where we do the knowledge that we have from the Snoop 10, or whatever kind of time critical condition red flag checklist that we have for a condition. Either we do a read-do kind of way where we just read out loud, like point one, like the first point. Did it come abruptly? Yes, no. Did it come like kind of an algorithmic way? And this does have some value, but it has to be much later on in the encounter. It's also why a lot of the phone triage things are sending in a lot of patients, because they gear their questioning like that, like for high sensitivity and low specificity probably. I do not know this is fact, but it seems like that is what they're doing, because they don't want to miss anything. But if you drive your sensitivity up through the roof, then your specificity will usually plummet, and that's why we get a lot of patients that are scared because they're primed through this phone triage that go to the emergency department right away, and they think like the emergency department is somewhere is the place where people are really, really sick. And am I then really sick, or am I in big risk of being really sick? So I would love for these phone triage things like 1813 or 1177, 1813 og 1177 in Sweden and Denmark, respectively. I would love for them to like just do a small note of what is the condition that through their algorithm, what is the condition that has arisen, what is the reason why they should go in. Just a small note, because then I can much more easily assess whether when I encounter them, whether this is plausible at all. The other condition, which is the other way of attaining information, is by asking an open-ended question and either not having anything in your thought realm at all, because you're actively listening. You're trying to know what the problem is for the patient, and for you to do that, you have to actively listen and not think about anything else. That is a good way to do it in the beginning of the conversation, and just a bit more further on, then you have your Snoop criteria in the back of your head. But you don't ask directly about them. You try to ask wide open questions or semi wide open questions, especially about the like you can't go around asking wide open questions all the time for every encounter. But in the beginning of the encounter, it's really important, and as you gather more and more information and you own in on what the problem is, then you can go more and more specific. We can call this the do confirm kind of way, because the do confirm checklist is done by you doing a bunch of stuff, and then you're using the checklist as a forcing strategy for you not to miss the important stuff that you might not contain in your head all the time. So you ask open-ended question, and you go back and say, look, oh well, what is this condition? Sorry, have I thought about all the time critical conditions that I need to assess here? Okay, so I suggest that you do the latter one here, especially in the beginning of the conversation. So why do I do that? Well, it's Tricia Greenhall and Gary Klein who talks about, well, our patients are complex, right? When we are working with complex things, it's not a linear model like, well, if the condition A arises, then do B. It's more like you have this undifferentiated patients, and when you go into when you assess them, it's like going into a cloud of uncertainty, right? In this cloud of uncertainty, there will be some areas in the cloud where there might be some like security, some guidelines. Like we know that, well, if you have this condition, then you can use the well score, and then you can just follow the algorithm. Then that's all right. That's what they're used for. That's why they're useful. These clinical decision tools, as Ken Milne will say. But you need to know whether the condition has arisen, and you need to be content with the fact that often you don't end up somewhere where there is a street light, and that's all right. I mean, most conditions are not capable of being put in boxes, even though we are forced to put them in boxes of diagnoses or whatever other kinds of boxes. But we should be aware that we are often harming patients. So I would rather just say, well, there's a low probability of this being anything dangerous. I don't know what it is right now, but I suggest that you go home and do this, like do this, and then go to your GP, or I mean, you don't have to have a diagnosis, because if you put something that shouldn't be in the box into a box, then sometimes your patient will just fit into like they will accommodate the box so that they will get the condition. So if I tell them maybe this is muscular pain or this is hypertension, then they will obsess about sometimes these things that I'm telling them. So leave it a bit open, especially in the emergency department, especially in the early phases of the diagnostic workup, because most conditions will go into like our self-limiting, as I told you earlier. Okay. Sometimes we do have to like extrapolate if we're thinking of a critical condition, and we can extrapolate, and we can do a bit of extrapolation, but sometimes and more I think we're doing too much extrapolation. We're doing this creep thing again, and if we're ending up here, well, I mean, we might as well, because I mean it could be a chest pain that we should work up and so on. And actually if we include these patients, we're just doing lower and lower value care for them. Okay. From the patient's perspective, they're coming in with a frame, right? A empty frame. They need help and they don't know what to do. That's why they're here at our door. So if we sit down, ask open-ended questions, listen actively, and fill in the gaps with specific questions, then we usually will get like a quite homogeneous picture, and there might be some spots that are not filled in, but that's all right. We'll get that with our specific questioning later, and of course we're not interested in emergency medicine of painting the entire picture. That's not our purpose. Our purpose is finding this bad stuff. But if we don't know where we are, if we don't know our bearings in the history here, then we don't know where to close the gaps, so to speak. So this is us closing the gaps. Maybe we order a specific, we ask a specific question, we do a clinical exam, or we do a paraclinical exam like a CT scan, to rule out if we think the diagnostic threshold is high enough to think of this condition, right? So what we might say, as they say in Sapira's book of bedside history taking, don't lead the victim when to the street light, right? I can easily ask my questions for thunderclap headache so that I'm leading my patient who is scared to be in the emergency department, might not have been listened to probably, and might have been primed throughout the system, coming to the emergency department with a headache they are now really, really afraid of, having been waiting for 8 hours. I can easily, if I ask, well, did it come? Is it an intense headache? Well, they will usually say yes. And did it come abruptly? Did it come quickly? Then they will usually say yes as well. And if I just blindly say, well, you said yes to both of the criteria, then I'm leading my patient to the street light. Instead, what I should do is ask these open-ended questions, how can I help you today? And be empathetic about it, which I will come back to. If I do that, then they will usually tell me a story, and I can pluck, well, did I think this is an abrupt headache when they talk to me like this? So when they give me this information, and usually you'll get a much better assessment. Well, I woke in the morning. Well, I do usually wake in the morning. Yes, I usually wake in the morning at 7. So you woke with your headache, not because of your headache. I mean, this is the clinical art of medicine, right? This is what we should be experts at, and this is what is really hard to attain through studies, and which goes missing in the evidence-based literature oftentimes. Okay. If we do this the other way around, if we do this priming or specific question, hurry, unempathetic, and exam test oriented, just ordering the CT, then we will usually not get a thorough picture. We don't get our bearings, and the patient doesn't get feel like they didn't get listened to. I mean, they get a test, and oftentimes there's this third segment of the of the conversation, that we're usually not talking about this emotional pathway. Like we up till now we talked about the diagnostic pathway of the conversation, but Laura Rock and Vital Talks has taught us about through SMAC and Mastering Intensive Care podcasts that you have this other conversation going on when you're talking to a patient. And if you say like, well, I'm sending you home now, and your patient says, well, I'm afraid there's something wrong with my head. And you just say, well, your CT scan is normal. And they say, well, I'm afraid there's something wrong with my head. And then you just, well, your neurological exam is also normal. If you answer an emotional cue with facts, with logical facts, then you will be missing, and then the patient will feel like they're not been listened to. Instead, it's important to try to. I hear you. I can see that you're afraid. Laura Rock gives this mnemonic called GIVE, like get, there is an emotion, investigate, validate the emotion, and explore, right? The eyes identify. So it's like, oh, there's an emotion here. I get it now, right? They're saying they're afraid. Well, that is the eye identify. Okay, it's anxiety. Validated. Okay, I hear that you're afraid. That's so frustrating, right? Is that is really, I can empathize with that. And explore, do you know, is there something specifically you're afraid of? Or, I mean, that is a much more wholesome and much better way of getting to these problems that our patients are feeling, instead of just doing tests on them. Okay. And oftentimes when we do these priming questions, we miss the bad stuff as well, because we don't get our bearings. We don't know the problem, and we don't hear what the problem is. Okay, and oftentimes patients go home with an empty frame. Their problem wasn't addressed, and they will come back tomorrow, and tomorrow again, until that problem is addressed. Especially in an open system where you can just come to the emergency department. And that's not the patient's fault, that's the system's fault. And that is our fault as doctors failing. Okay. So I'll just go into details about this. Good communication achieves two things. So my method is this. Let's start off with the diagnostic part of it. So what I just explained to you is that I want you to, the diagnostic conversation with your patient, I want you to lead with an open-ended question. And the purpose of this is to get the patient to tell their story like a story, because it's really important, this storytelling. The patient feels that they got the opportunity to actually tell their story, and there's a lot of things that you would never think of that are clinically important, that are lost if you interrupt them too early. So don't interrupt them. Sip, as we usually say. You of course you can nudge. This is a conversation, not a. I mean, sometimes you need to be really fast with your questions, and that's the resus mode usually. But just know that there is a risk that you're missing out on a lot of information. But that's okay when it's a resus, because there's another kind of you need to get to a different place quicker, and you're okay with doing over testing because they're in a bad way. But this is not the thing with the stable patients. You need to stay quiet so that you can get the information in the best manner possible. All right. So you can occasionally nudge them, because that's part of the conversation. Well, like say or not, or try to clarify if you don't totally understand what they're saying. And that's just that's from your initial open-ended question, right? They're still telling a story here. And you're actively listening. You use all your senses, as Scott Weingart tells us in Resus, just as in the same way you should listen actively in In this situation, Scott Weingart tells us in OODA loops and bread baking, and Gary Klein tells us all of this. Seeing what others don't, that is active listening. And you need to know, you need to, when you're listening actively, you should be able to, when the patient is done speaking, you should be able to summarize and even summarize their argument or summarize what they're saying and even build upon it and make it better, even if it's not in your favor. That's more general about active listening. But you listen with all your senses, and the purpose is to understand what your patient is saying, so that you understand the problem, so that you get your bearings and you know which way, what the reason was for them coming in. Oftentimes it's not because of they're afraid of this is something dangerous. Oftentimes it's because some of the phone people algorithmically have sent them this way, or they wanted something totally different but they didn't listen in the phone, and now maybe you're not listening either, and then you're on this pathway of disease or cascade of bad care. And that's I mean, so active listening is really important. Again, and last thing I wanted to say about active listening is this: use the negatives as well. Like, what are they not saying? You might have a really stoic patient who doesn't really complain of their headache or their pain somewhere, but they came in the middle of the night and has never been here before. Well, why is that? Maybe they're even in Denmark from Jutland, or they might be in Sweden. We usually say if they're from Finland and or Norland. Like, all regions have these more stoic populations where there's a higher degree of stoicism. And if they come into our emergency department, why do you come in the middle of the night? You've never seen us before. That's like listening for the negatives. There's something they're not saying, or why their pain is probably much more severe than we actually what they're verbally saying. Okay, so we get this understanding of why they're here, what the problem is, right? That is like the 4 first points here. That's just the initial couple of minutes. It usually only takes a couple of minutes for your patient to tell their story and you to listen and understand. And it takes some practice, but this is quintessential what a doctor does. Okay, and then begins the doctor's part, right? And this is where you can use your syndromes and illness scripts, and you can now open up with semi-open questions. You don't ask, did it come abruptly? Did it come? You ask, as I tried to tell you before, how is your what time of day do you wake up in the morning? Well, at 7 usually. Okay. And this time you woke at 7 as well. Okay, well then you woke with your head, not as a you didn't wake from an headache, like with an abrupt headache like that. I mean, that's how you like pick out pieces of the story, instead of just thinking that you can, by doing specific questioning, get all of this information. Okay, and in the end, you'll do shared decision making. Not always, but oftentimes you'll be in this area where you don't know, you're a low process probability, but shared decision making is quintessential in evidence-based medicine, right? It's like a third of evidence-based medicine. The other 2/3 being the clinical judgment, as we're talking about now, and the best external evidence. So if you're not doing shared decision making, you're not doing evidence-based medicine, right? And there's a lot of ways to do shared decision making, and I'm not going to go into details about that. I will do that in the longer video. But it's really important that we don't fumble at the finishing line here. We've done all this great stuff for our patient, and we shouldn't fumble at the finish line here. You have to give them their story back, as Sanders in Every Patient Tells Their Story talks about. You have to give them the information so that they understand it, and maybe you have to write it down and all. Like, otherwise, who are we doing this for, right? Okay, so I think this method, this diagnostic method of history taking, is much better. It gives you better quality of data, not as much noise. It gives you better precise probability of evaluation, and less risk of certain cognitive biases, such as premature closure, anchoring, and so on. This is not it's not a golden bullet. There are fallacies about this, but I think this is the better way. Okay, so these are two waiting rooms, and I've talked about soft skills or non-technical skills throughout this lecture, but now we're getting really soft. This is a pediatric wardroom, and I used to work in pediatric emergency medicine. I loved it. And what you often see is like this really colorful, very, very calming kind of environment. And the reason why is because we know that children are really scared when they come in with a condition, serious or not. It's a new place for them. And this is our current, this is a booth in our emergency department where I work currently. And I mean, this is quite barren. I mean, this is good for emergency department as far as adult emergency departments go, but is this really a good way of like reducing people's stress levels? What are the priorities that we're doing why are we not thinking of reducing anxiety in adults as well? Or why are we not trying to make it more manageable to be in the emergency department for the patients? Especially if we work in an area where you have a lot of stable patients, right? You're just making them more afraid. So adults are scared too. So we should really consider, I mean, if the rooms are not doing this for us, if the environment is not doing this for us, then we as doctors have to be the ones who can calm down our patients through communication, through compassionate care. Okay, so there is, we need to bring this safe container kind of philosophy to our patients. In more than one way. We need to like lower the hierarchy. Like they are at our house, we work there every day, but they don't. They've never been there before. It might be the worst day of their life, and they're scared and they're hurting and they've been waiting in uncomfortable environment for a long time now, and we're just barging in there and not like addressing this. I mean, we need to bring this kind of safe container mentality, and you can listen more about this and at these with these links here, references here. But I'll try to tell you how through your communication, along with your diagnostic information or diagnostic tactic as I just told you about, you'll also do a therapeutic intervention throughout your conversation. There's a lot of talk about, we might call this compassionate care. Compassionate care is kind of, I mean, it's a spectrum, like sympathy, empathy, and compassionate care. So sympathy is, as a good TED talk tells us, and as Barbara Tatham tells us at EM Cases, the episode 145, like sympathy is looking at your patient down in the hole and saying, wow, that must be tough. Empathy is going down into the hole with them and sitting in the rubble, as Liz Crow tells us in her SMAC lectures, sitting in the rubble with the patient and just being there. But in emergency medicine and in medicine in general, we can't be entirely empathetic. We have to move. We have to do something, right? And that is the compassionate care. That compassionate care is empathy, but just maybe a half step back, so that we still have the overview to try to get the patient to the next step, to try to do something. And this wanting to do something for the patient, this is therapeutic in itself, even though that it might not do anything. If you think that it does, and the patient think that it does, and we're trying to do something, then that is therapeutic, and that is living up to the numbers needed to treat equals 1 kind of criteria. That is hugely important. I mean, most times in medicine we're we're fooling ourselves thinking that we can do something, fixing problems, and we sometimes can, but we often can't. especially not in the emergency department right now in the middle of the night, but we can be compassionate, right? And I think that this is so important. I think this is so essential, and I think we're doing this huge disservice to patients not doing this, because it doesn't take a lot of time, and everyone can do it. It's something that is learned. It's a skill. It's something that can be learned, and we should like teach this, learn this. Not just for our patients, but for ourselves. It decreases burnout, as they say in this book called Compassionomics. It's quintessential. Okay, so how do we do this? Sit down. Sorry, I didn't translate this. Sit down, because we want to non-verbally lower this hierarchy between us and the patient. We have all the power. They are in the bed, often not being able to move, and we want to open this environment for them. We want to make it safe for them to ask questions. We are not this authority, or we are this authority in their eyes, but we should try to. You don't dare to ask You don't dare to ask questions to an authority figure. You often get scared, or you just do what they're told, what you're told. But we want to lower this hierarchy, so that just as we are doing on the resus environment with our team, so that patients can come with questions that they are not afraid of asking them. And we'll do this along. So sit down. That's the most the easiest thing to do. Or crouch down and look them into the eyes. Do open body language, like palms out, eyebrows up, and smiles. Of course, it has to be appropriate, but usually when you agree, at least when you greet someone, that's a good way. Okay, then there has to come some empathetic statement quite quickly. Usually they've been waiting for a long time. So an empathetic statement like, sorry for the wait, even though you weren't the reason for it, it's good to acknowledge that they've been waiting. That's a good way to start. It doesn't have to be that, it might be something else, but some kind. It would be a great way to connect with the patient and build this alliance in the beginning. You might be aware that they're freezing, or you can see that they're in pain still, and you can try to, before you start, you can ask them, do you want some painkillers, or can I bring you a tissue or some water, or something to warm you with? This is really important, like seeing them as a person, just not just as another case that needs to be diagnosed. Okay, then introduce yourself and do tell them what the purpose is for you being here, because what is often happening is that Slate and it all did a huge study in Australia about this. One of the about communication in the emergency department, and one of the main complaints for patients were that we're not signposting enough for the patient. They don't what they hate the most is not the wait, it's not knowing what comes next, not knowing what's happening. And so if you can just explain a bit what is happening and what comes next, how the situation is going to be, what is next, then we can hugely decrease their anxiety and suffering. Then validate your patient, acknowledge your patient. And this is one of my pet peeves. When your patient tells their story, and you if one of your friends tells you a story about they have been aching and they've been in pain and something bad has happened to them, then you don't go into diagnostic questioning right away. Usually you don't anyway. You will stop a moment and acknowledge that, wow, that sounds horrible. That is the validation of the story, right? You might also use I can see language and not use factual language. Just that, I can see that you're hurting. I can, from where I'm standing, through my eyes, I can see that you're in pain. And that is especially important when they have been through a lot of doctors not believing, quote unquote, their pain. Usually it's not because the doctors haven't listened, it's because they haven't acknowledged it. It's because they just ordered tests instead of actually seeing them as someone in pain. Okay, so this is important, like the validation of the symptom, like, and following up on the validation. Usually I go into like, I can understand why you came here. A lot of your patients will be really embarrassed of being in the emergency department. They know that the emergency department is somewhere where you go for emergencies, and they're not sure whether there are cases in the emergency, and they're really embarrassed because they can often see like people being really in a bad way. Some of these high signal cases, you can really see them being in a bad way in the emergency department. So they are embarrassed often being in the emergency department. We know this from studies as well. So if you can defuse that, like, good thing you came. I can understand why you came here. And thank you for telling your story. It's really hard to do this in this kind of environment. I mean, these validating statements are so important, so I can go on, but this is how you gain the trust and alliance oftentimes for your patient. And then do an expectation management, right? So especially for headache patients, but also for a lot of other pain patients. Usually sometimes they come to the emergency department because they want to be pain-free, and it's really important to upfront tell you our purpose. My purpose in the emergency department today is not to get rid of your pain. It is to decrease the risk of this being something really bad, right? Something that you could die from before you see your GP or before you go somewhere else. So that's my main purpose. But, and this is really important to use this kind of language, I think. But I think I will do whatever I can to decrease your pain. And then I wish kind of, I wish I could, if I had a pill that could remove your pain right away, I would do that in a blink of an eye, because I can see that you're in pain. I would do that. I have a cocktail that I will try to use, and hopefully that will decrease your pain. But I might have to send you home with some or all of your pain after this workup, because I'm not sure I can help you with all of it. But I can, like, pain goes away through, like, then you can go on to like the prognostic kind of way and how you will tell that to the patient. But it's important to know, like, convey that for the patient that you're on their side, right? I wish I could take away your pain. I will do my best to do so, but also manage expectations, right? Because when they've been waiting for 8 hours and they got the CT and you're sending them home because, well, the CT is normal, bye. Then they're still like, but you didn't treat my pain. That's why I'm here. And so it's really good to, like, upfront assess that what is their expectations today. It's something called the 5 model, or the 4F model in Denmark. And it's a really good way also in the emergency department, even though that is from private practice, also in the emergency department to use this. Okay. If you do this right, and I really, I can't stress this enough, it doesn't take a lot. If you do this right, you will get a therapeutic alliance in some way with your patient, and you might, like, whatever treatment that you're using on your patient will have an enhanced effect through the placebo effect, or what Jonas might call the meaning response. And they will have a feeling of being addressed, like the problem being addressed, them being taken seriously. And that's so important for anyone in any condition. Okay. So what we're doing here is, like, actually we're, from a diagnostic point of view, through this therapeutic kind of way, kind of assessment and treatment through communication, we're doing a great thing, actually, because this is your headache patient. They're saying my head hurts is like a visual and analog scale of 10. And what actually is inside is like this biopsychosocial structure, like reason for their headache. There might be a biological reason, but usually there's a huge psychosocial reason, and the environment of the emergency department and not being listened to, and the anxiety of being there is usually a huge contributor to their pain. It's modulating their pain. If you know about the pain gate theory, the gate control theory, and then you'll know that that these things modulate. So if we take away some of this through a good communication and good bedside manner and like compassionate care, then like the unpleasantness of being in the emergency department goes away, or might go away somewhat. They're not as embarrassed anymore because we told them that it's really good that they're here. Their expectations of pain-freeness goes away, and it's more nuanced maybe. We might decrease their mistrust in doctors. We might decrease their uncertainty, and oftentimes just through a decent assessment, we will decrease their risk of being in great danger with their headache. So their headache, through this, we might have gotten their headache down actually. So, and we'll like this information that we're gathering would be less noisy, like it will have a higher quality. Okay. This is not as I said, this is not a golden bullet. Sometimes it doesn't work, but I think we should always strive to do this. And I think, in my opinion, I've seen a lot of headache patients in different settings, in neurology, in pediatrics, in psychiatry, in inpatient care, in outpatient care, in the departments. I mean, this is really one of my favorite topics, and this is really something that helps your patients. And I would go as far as to extrapolate this to all disabled patients in your emergency department, and also the resus patients. Okay. So Barbara Tatum tells us this: people will forget what you said, but not how you made them feel. I don't remember where the quote was from, and I think it was misquoted even, but I think the essence of this is so important. And in the end here, I will just, we're moving towards the end of the lecture, and I'll just say that, well, maybe you'll just say, well, I can't afford to spend time on that, like sitting down with your patient and you give them the time to talk and all. Well, can you afford not to? I will counter, because we talked about this. This is a hard line to balance, and I think the best way to do this is through good communication in the stable patient. I'll just give you these last couple of slides here. You have something called the inverse U curve of time, it's something that Fadovich et al. And Kaisers and their team in Western Australia talk about it. They're both emergency physicians, and I think maybe even professors. And they're talking about in these references, they're talking about the inverse U curve of time. And I've interpreted this as being, well, if you use too little time, you are in great risk of doing this, like not getting the history, not getting your bearings, and actually premature closuring on your patient, maybe overdiagnosing, and actually creating crowding just by doing tests before you do the assessment. Of course, you can't stay too long in the patient's room, because there will be other patients in the waiting room that needs assessment, and depending on your emergency department, you might be the only one doing that assessment. So there might be a flow problem if you stay too long. So there's this Goldilocks zone that you need to hit, and it might be different for different patients, right? Depending on their signal. And if you want to know more about some of these things, follow the links down here. But also follow Samuel Campbell, and I think he's a colleague of Patrick Croskery in Canada. Patrick Croskery doing a lot of research in this decision-making kind of field. And it's one of the gurus in when it comes to system 1 and system 2 thinking. and professor in emergency medicine and also a psychologist, I think. So check out those articles, and then I'll say this, like, you probably aren't saving time by just ordering your tests even though you feel like it. I mean, of course, the physical, like, you can do other things while you're waiting for a test, and that's the force of it. That's a good thing, and that's why I don't discourage all of, like, this tactic, like just doing a test before you maybe see the patient, or before you have done a decent assessment. Sometimes that is a good thing if it's a high signal, right? Because then you can do a lot of other things meanwhile. But usually you will come into maybe some stupid situations, and you won't be saving time. You will actually just be crowding your department. And I had this example when I was seeing a patient in the emergency department, handed over by one of my colleagues. He just the patient had just come in, had flown from France, and had just landed, and the patient had told us that, well, from the ambulance we were told that, well, the patient had shortness of breath and just landed from the airport, and has a history of a DVT. Well, I mean, that's a slam dunk, right? We had a lot of patients to see, and it would be great. And this patient needed a translator. There was really a long conversation, and I would need a translator both for the diagnostic workup and then order a test, and then once more. That would be, it would be much better just to order the test now and then be done with it, and then and then talk with the patient in the end when I had the test. So I did so. I did a CT of the chest for pulmonary embolism. It was normal. And when I came to the patient's bedside, he told me in French through a translator that, well, it wasn't dyspnea that was the problem. It was he had eaten some peanuts on the plane, and he had gotten red, and he didn't, thankfully he hadn't had a anaphylactic shock or anything. Of course, that would probably have been caught as a needle, as a big needle, if they had that. But it wasn't. But I mean, the entire situation, like, we entirely missed the story and radiated this young guy for no apparent reason. So it's complex, this. But what I wanted to get at is that you're not probably, like, you're doing a test to save time, and sometimes you are, but often you're not. And I love this quote from EM Cases on crowding, the podcast on crowding for EM Cases, EP 129, where they say, overtesting contributes to overcrowding, right? The more crowded it gets, the less time we spend with each patient, and the more likely we are to order tests to make up for poor history and physical, which leads to longer lengths of stay and backed up labs and radiology departments. While some patients may say that they come to the ED for a test, a thorough history and a physical with a clear explanation of your assessment often is more effective in satisfying the patient than rushing through your assessment and ordering a test that is not necessary and may lead to iatrogenic harm. I mean, this sums up most of my lecture. I think this is so important. So who are we doing this for, right? We're doing this for the patient, and I know all of our patients in the waiting room are also our patients. But if we can't do a decent assessment of one of them, how can we do it of all of them? And whose time are we actually? I mean, I'm measured right now where I'm working. I'm measured for by this, like, 4-hour rule. And there's this problem that, like, the currency of our system is, as I talked about in the beginning of this lecture, the currency of our system is this notion that, the currency of our system is this, like, things that can be measured, right? For in our department, it's the 4-hour rule, and if I don't get within the 4-hour rule, then I'm not a good doctor in this kind of system. And that's a problem because, well, yes, our patients shouldn't wait unnecessarily long in the departments, but is that really that's applying a very linear rule to a complex system, and we'll just gamify the system. We'll just draw the lines differently so that the 4-hour rule doesn't apply here. Or well, I just make a small apartment in our emergency department where I say that, well, that's the waiting area and that counts as the department, so I can just put them there. But for the patient, that is not a good thing. So and I often ask this, like, whose time are we actually on? Who are we trying to help? Because it's my time. It's the 4-hour rule. That's me being measured on that. But and I will have I've done a good job if I stay within that. But the patient's time is always like the patient's time doesn't, like, the patient's clock doesn't stop when he or she leaves the emergency department. When he or she has to go again tomorrow or go to her GP or whatever, because we didn't do a decent assessment or didn't get them to the next step, just order a test and say, hey, bye. So so we this narrow view of our department, our time is not only paternalistic, it's kind of, it's ineffective, I think, for in a system view. I love this quote from Iona Heath's book, article, Arm in Arm with Righteousness, and she has so many great quotes and so many great articles. I urge you to read some of her stuff. She says, at the moment we waste effort, money and time collecting data and pursuing quality targets so that we have less time to listen, and we risk losing sight of the suffering human subject. And we risk destroying quality on our attempt to measure it. And this last sentence is so important. We risk destroying quality in our attempt to measure it. All the unmeasurable stuff that I've been talking about in this lecture is what I think gives quality to our patient encounters. But usually it's unmeasurable. And if we're filling up the entire space of like what counts as currency in our system with something that can be measured, well, then there's no space for all the unmeasurable stuff. We should leave space for the unmeasurable stuff. I do think there's certain good things with measuring stuff, but it has to be really specific, and it has to be like, we need to know what we're doing. And up until now, I don't think that is actually something that is happening. I think the administration doesn't speak our language. We don't speak theirs either. We need to close that gap between the administration and us. And maybe even take a page out of Daniel Coyle's book on leadership and maybe become leaders ourselves in our departments, so that we get the mandate to change things in real time. I urge you to read Daniel Coyle's The Culture Code, and also Jeffrey Braithwaite's BMJ podcast, Changing How We Think About Healthcare Improvements, and also reading his article, because this notion of complex systems and simple solutions in a complex system is so it's debilitating. It's destroying our society's healthcare system. I think Don Berwick has talked about a lot of this as well. And if you want to read more about some other ways that this is a problem, because much of what we're measuring doesn't really add up to a fair, like, the treatment that we want to give patients maybe isn't as effective. Try to check out John Ioannidis on any of his lectures on YouTube, but there's a great one from his keynote from Lawn Institute. There's one from ScanFoam where he talks about reducing waste in healthcare, and there's one from there's a podcast from the Cochrane podcast by Ray Moynihan called The Recommended Dose, where Ioannidis talks about how we are actually destroying ourselves with this kind of measuring, and also how we cannot get away from what we're currently doing because we have vested interests in it. Okay, so my take-home point is the good communication is like bobsleighing, right? Invest in the beginning, and everything will go faster. If you see bobsleighing, then it's really important. The first seconds are much more than if you do a great start, then you will be much better at the end than if you do a great middle. And so seconds in the beginning are much more important. But that doesn't mean that if you get a good start, you can just sleep your way through the rest of it. You need to be aware through the entire thing, but the start is especially important, right? So yeah, the larger lecture on 4 hours, which also goes through a bit more details on interpretation and system 1 and system 2 thinking, is on the internet. So just to sum up, if we do this compassionate care, we get more satisfied patients who will be suffering less, is my thesis. We will get better diagnostics because we will get higher quality of data, and we'll get less noise, and we will probably also be less prone to cognitive biases. But that's a conversation that I delve into in the longer lecture. And then this thing, less burnout, is really important because on the one hand, we can't, if we are depersonalizing, and if we are cynical as our symptoms of burnout, then we can't be empathetic. But if we were too far out on the spectrum, then it's probably not a good thing to continue. But we need help. But we are all somewhere on this burnout spectrum, especially now during COVID. I think it's important to acknowledge the fact that not just seeing patients as patients, not just moving the meat, but actually doing something like sitting down or being compassionate. All these things that I've talked about will actually, according to in my own experience, but also according to the book Compassionomics and the TED Talks of the authors, it will lessen your burnout. Not a lot of science on that yet, but I do really think that is true inherently, because it creates meaning. If you want to know more about that, look up Liz Crow's podcasts, Liz Crow's Smack Talks, and St. Emlyn's blogs, and Peter Brindley. Yeah. Okay, so it's very simple. Like the doctors. So in the end, we talk about the patient's well-being, but actually the doctor's well-being is the patients always come first. But for the patient to be able to come first, we need to take care of the doctor and the nurses as well, because they're not isolated. We cannot take care of patients if we don't feel good ourselves, right? If we don't have a good environment, if we have a system that blames us all the time, if we have this risk proximity weight on us, all of these things are so important that we talk about. Okay, I do talk about these in the blogs, but I'll just leave that open for now. We've made 2 documents in Denmark. I've been co-editing both of them. One from younger emergency physicians, and one from the Danish Society of Emergency Medicine, about work-life balance and work environments. So this is something that is really, really important for all of us. We are all patients in this system, and we want the best, so we need to fix this. Lots of links and references, but some of them are these. There's this great one as well by Solman. Check them out. And so the take home is this: good communication achieves 2 things at the same time. We do a great preset probability assessment if we do have the knowledge in our back of our mind, and ask open-ended questions in the beginning of the conversation, and sip don't interrupt. Then we're able to understand what the problem is, and then do the doctor's part, where we can, from our knowledge, talk to the patient about like filling in the holes of like these time critical conditions. If we do this with the compassionate care, I believe that we will be able to treat a lot more pain. We will be able to reduce suffering, and we will be able to live up to all of these three things that are the purpose of emergency medicine. And it doesn't take that long. We can practice this. It doesn't take more than it really doesn't take any longer. Usually it takes longer just to order your CT, backing up, crowding your departments. Yeah, I'll leave you with this. And I thank you so much.